Hi, and welcome back. Next speaker up is a colleague of mine at Technia. His name is Paul Bolkos. He is a real expert within the simulation field. And what he will talk about is the PhD work that he did regarding how to use FE models in order to predict knee joint osteoarthritis. So in other words, how can one use simulation tools in order to predict certain outcomes and how it can help patients at risks, and in this case of osteoarthritis. Now, thanks and welcome on stage, Paul.
Good afternoon, everyone. My name is Paul. I'll be presenting some of my PhD work. And I'm currently in the Technia Simulation Center of Excellence. And the presentation is going to be mainly focused on predicting some knee joint diseases using finite element models, or simulations in this case. Before we go into that, I'd like to thank Technia for the slides on the PLM part. So going through the sort of key advantages of PLM in life sciences, first you have the personalized health, where you have some patient-specific aspects that are included in the innovation process to achieve a higher level of personalization. Then you have development and manufacturing, where you have some high-quality personalized products that are achieved through predictive and adaptive manufacturing. And there's a quality and compliance, where you have quality embedded into each stage of the product lifecycle, and it's a part of the compliance control. Then, of course, there's knowledge capitalization, where you connect systems and people and data in basically in an integrated virtual system to ensure that the information achieved is reached at the best time to inform the right decisions. And then, of course, you have the transformation of the value chain, where you have integration as a whole of the entire value chain, including the collaboration, integration with patients, physicians, and partners. When looking at that, I had two main questions. First is that typically PLM is adopted into life science industry, so why not in academia? And a bit more towards my background, why not also include the simulations in the PLM cycle? And this is what I'll be focusing today on. And for that, we'll be looking at an example of the knee joint osteoarthritis. So here you see an animation of a healthy knee, where everything is smooth and all the cartilage, all the structures are fully healthy. Then as the disease occurs, the cartilage, the soft lining tissue starts to crack, and then you have some bone spurs forming. These bone spurs will start to grow, and the cartilage will also start to deteriorate more, and you will see some joint pain and some severe symptoms occurring. Lastly, in the final stages, you have full cartilage deterioration. You have bone-on-bone contact, which is quite painful, and you have very big bone spurs, and you can see this kind of grinding motion of the knee joint. Currently, there's no cure for osteoarthritis. The total costs are around 450 billion a year. And towards the end stage, or severe OA, the solution is a total knee joint replacement, which can be between 10K and 25K per patient. Wouldn't it be better to develop a clinical tool to predict the knee joint osteoarthritis and maybe prevent or delay that disease onset and progression? And the focus here is mainly on detecting the disease early enough to enable the prevention, and it's done using finite element models. And in the right-hand side, you can see that the dark area has some mechanical parameter that is exceeding a certain value, and that may develop osteoarthritis later on. To make the patient-specific finite element models, there's general workflow. You have a geometry taken from an MRI. You have some loads and boundary conditions that are taken usually from motion capture. You have some material properties that are usually taken from material testing. Those are all fed into a finite element model, and you have some results. And in the first research case, it mainly focuses on methodology development. So the MRI geometry part is still the same, but the loads and boundary conditions has changed. So the motion capture system is enhanced using electromyography, so you get a more personalized muscle activation pattern, and that is also fed into a musculoskeletal model that makes the personalization even higher. The material are not changed, but then you have a much more complex finite element model. And this workflow is usually used, you only change one thing. So in the methodology development, the focus is just on improving one key aspect. And that usually takes anywhere from 2 weeks to 1 month to do. And then there are some key parameters that we look at. And generally, it's just to ensure that they are within reasonable ranges. And here, for instance, you can see that the finite element model is within a reasonable range compared to different previous studies from other researchers. As a secondary research, we focused mainly on verification and validation. In this kind of scenario, we don't necessarily use validation because that would imply that we are measuring the exact same thing, and which we are not. But most of the workflow is identical. The finite element model is simplified, and the main focus is just to make sure that the predictions match what the finite element model is doing. So here we have on the top hand side the finite element model that predicts something happening on the right hand side of the cartilage, and then from the MRI follow-up you can see that the same area is degenerated. Even going a bit further and adding even more patients, you look at the predicted degeneration versus the measured degeneration from MRI, and you can essentially assign risk levels from the finite element model that match the risk levels from the MRI. So quite in 85% of the subjects we got, we managed to predict what was happening. And the model generation time is usually around 2 weeks. But to make this into a clinical application, we need to improve this kind of workflow. So then there's the automation part, where the whole workflow is automated. Mainly, we're focusing on the geometry and finite element model. So for the geometry from the MRI or a CT, you measure 5 dimensions. You search in an atlas to find the closest match. That closest match is then scaled to match those dimensions, and you get the finite element model. And this whole process takes 1 minute. And in a previous study, the researchers were able to have a prediction accuracy of 80%. So 17 out of 21 subjects were predicted correctly. Here, the main issue is that the loading is generic, so it's taken from literature, and the finite element model is a lot more simplified. So you would want to essentially integrate each step into one full cycle. And going back to the life sciences and PLM, you have the development and manufacturing and also the quality and compliance. And you would have a loop of methodology development, verification, validation, automation, and this would continuously improve. When talking about knowledge capitalization and transforming the value chain, you have a collaboration between universities. Here, there's the University of Eastern Finland, where I did the PhD study. There's Leuven and other research institutes. Then you have hospitals and medical databases. And finally, you have a lot of funding agencies, ranging from the European Research Council to the National Institute of Health in America. And all of these need to communicate much more fluidly between each other to enable a faster development. And going towards the personalized health and quality and compliance, here there are a few examples where personalized health was used. For instance, in the left-hand side, you have a mechanical test that is in a finite element model, and that is sort of matched onto each other. Then in the middle, you have a total knee joint replacement, and you can simulate the geometry and the shape of that knee joint replacement, perhaps informing on how the surgery should be performed. One of my colleagues did a stent deployment analysis, so you can simulate how a stent would be deployed in a coronary artery. Other people looked at how the shape and size of tooth implants should be, the fillet size, and that could be simulated using finite element models. And lastly, on the bottom right-hand side, you can see a full spinal model that can be used, for instance, to look at different problems in the spine, such as multiple sclerosis and other diseases such as that. So if you could develop a simulation that matches the experimental follow-up, it would make the quality and compliance faster, and the FDA and MDR approval process maybe even more streamlined. Going a bit into conclusions, so for life sciences in PLM in academia, it would help to expedite and ease method development. So you would have a nice workflow of developing a method, validating it, automating it, and then repeating the same process. It would bring such innovations faster to the market, and it would integrate regulatory bodies and other decision makers such as the funding agencies and hospitals. And finally, it would increase the collaboration and the integration with patients, physicians, and partners. Then when we look at why would you use simulations in PLM, first you could validate new designs at much lower costs than traditional testing. And you could have fully personalized predictions of patient outcomes. And in the future, these kind of simulations may even fully replace traditional mechanical testing. And with that, I would leave you with two key things taken from our Technia site. One is from Mina Siltala from Orion, who said, why reinvent the wheel when you have a functionality embedded into systems from Technia's PLM part. And from Lars Nord from Cytiva, who said that if a company grows, you cannot afford to have 20 systems, but if you have 3 systems that we work hard on and integrate them, then that's basically a prerequisite for scalability and sustainable growth. If you have any questions, please drop them in the chat, and I'll also be available in the panel discussion.